Welcome to Trio and Happy New Year. It's great to see all of you folks. I'm Marty Marion. This is my wife, Michelle, and we manage Trio Maryland. And today's topic is a winner, medications after transplant. It's such an important topic, and we're so glad that you were able to join us for it. On March the 11th, I wanted to remind you that we will be having another Zoom meeting, and we will be celebrating National Kidney Month, and our speaker will be Dr. Silke Niederhaus from the University of Maryland. It's going to be a clever talk because she is both a patient and a surgeon of transplant.
Hi, good morning. Happy New Year. Today's guest speaker is Ian Booth, a solid organ transplant clinical pharmacy specialist. Say that 4 times. Ian is originally from Jackson, New Jersey, and we thought he obviously would be an Eagles fan, but he is not. He's a Giants fan, so he's rooting for the Chiefs. He completed a bachelor's of science in chemistry at Westchester University of Pennsylvania and a doctorate of pharmacy at Temple University School of Pharmacy. He completed 2 years of pharmacy residency training, including 1 year of solid organ transplant specific training at the University of Maryland Medical Center. Ian now practices as a solid organ transplant clinical pharmacy specialist at the University of Maryland Medical Center, and he also serves as assistant professor at the University of Maryland School of Pharmacy. So we are really lucky. We've tried to get Ian a few times, but he's really a popular guy, so we haven't been able to kind of book him. So we're blessed today. Thank you, Ian, for presenting to our group. Welcome, and I now am going to turn the program over to you.
All right. Good morning, everyone. Thank you, Marty and Michelle. As Michelle mentioned, I have been trying to present to this group for a few years, just never seemed to work out. When COVID first hit, that was my first planned in April of 2020, and then it got canceled and I wasn't able to do it since. So I'm very happy to be here to share, some medication knowledge and hope that we can get some questions answered. But before I start, I also wanted to just share a little bit more about myself in terms of kind of why I got into transplant. So back when I was in pharmacy school, I had a very close friend pass away. And at that time, I didn't really know much about transplant. It was kind of new to me. And when her mom told me that they were going to donate her organs, that was kind of the first intro I had to that. And that's kind of really what set the next few years of my career and how I got into this field. And to be able to honor her as a donor, she was able to save 8 different people with different organs at that time, and that was back in actually 2014. So it's been quite a few years, but I'm happy to have continued my path in transplant, and I'm happy to be able to give back a little bit to other past and maybe future recipients that are on this call. So as I mentioned, we're going to be talking about medications after transplant. And so there's a lot of information that we're going to go over in this slide. A lot of this is meant to maybe be a little bit more of a recap if you've already received a transplant, or maybe give you a little bit of an intro if you're on the waiting list to receive a transplant. And as Michelle and Marty mentioned, this will be recorded and will be posted, so you can refer back to this as well. I'll try to highlight some of the major points, but I want to make sure I leave plenty of time at the end to answer any questions that anyone may have. If you have anything that comes up as I'm going that seems extra confusing, please stop me and I can try to recap, but I will have some time at the end. So here's a little bit of an overview of what we'll go through for today. So first, we're going to talk about just kind of the history of organ transplant and some concepts of the immune system that we think about when we plan our immunosuppressive medications. Then we're going to talk about the common medications to prevent rejection after transplant, what to do if you're experiencing any side effects from the medications, and then recognizing the importance of how to prevent infections after transplant, and then some strategies to make sure that we're taking all of our medications, because that is the most important thing that we can do, is to adhere to all of the medications that we have. So we'll start off with some overview of the organ transplant process and immune system. So here's a little bit of a history lesson. The first kidney transplant was performed back in 1950s, and you can see ever since we've done various different organs. But in the meantime, a lot of our immunosuppressant medications have come out during that time. And so really the first major breakthrough that we have had with our medications was in 1980. So really not that long ago. And the area of transplant is a very big growing field, and we still have a lot of room to grow in terms of the medications we have and what we can do to help our organ transplants last even longer. Why is it so important to become an organ donor? One donor can save up to 8 lives. And although transplants continue to go up in terms of how many we do in the United States every year, the need is still very great. So there's over 114,000 people on the transplant waiting list, and every 10 minutes a new person gets added. So you can see that there is a very high demand for organs in the country. Here's just a picture of what can be donated. So various different organs and tissues throughout the body. And every transplant center may do specific organs or specific tissues, but all of these are possibilities. Switching gears into the immune system a little bit. So obviously the immune system is the most important aspect of organ transplantation and how we're able to successfully transplant an organ. And so the immune system, I break it down into 2 sides. So the good and the bad when we're talking about immunosuppression and organ transplantation. So the good being on the left-hand side, we're trying to protect this new organ or protect our body from various different bacteria or pathogens, things like that. But in this case, it's an organ, right? So we want to protect that organ for as long as possible. But then on the bad side, because our immune system is very strong and we have the ability to fight different things that come into our body, that can cause rejection and potentially even destruction. So it's a very fine balance when we talk about the immune system and how we control all of the different aspects. Here's a slide showing kind of the basics of the immune system. And really the major aspect is that we're going to protect us against foreign materials. And again, because we're talking about transplant, this is what the focus will be for today. So the organ is kind of what that foreign material would be in this aspect. And then there's 3 levels of defense that our immune system has. So the surface barriers being things like our skin that protect us from everything just getting into our body. The innate immune system, which is what we're born with and it develops over time. And then the adaptive immune system. And this is really the core aspect of what we think about for transplant. And so there's different types of cells and antibodies that are produced over time that fight off these new organs, which we want to prevent from happening. We don't want our body to fight off these new organs. And this is where a lot of our immunosuppression that we'll talk about really work in our body. And you can see that the effect of immunosuppression has also gotten better over time, and the ability to keep our organs has improved over time. So this graph shows the year on the horizontal line on the bottom going left to right, and then going from the bottom to the top, in 0 to 100 is the percent of patients that have survived. And you can see that the gray line continues to go down, so there's less rejection over time. And over that same course, the black line is showing that the amount of patients surviving has also increased in that 1-year timeframe, which is awesome news. And the reason for a lot of this change is medications. And so back in the 1960s, the medications that we had were really prednisone, or commonly a steroid, which we'll talk a little bit more about later on. But we didn't have many other medications to help prevent rejection from happening. In the 1980s, as I mentioned prior, cyclosporin was introduced. So this was like a mainstay of a new immunosuppressant medication and improved both of those outcomes. In the 1990s, we have things like our tacrolimus, mycophenolate, so common things that you may have heard of prior or may currently be on, and then even something like sirolimus. And then lastly, in the 2000s, so only about 20 years ago, we have our extended release tacrolimus, which I'll talk about, and even our everolimus. And so, as I mentioned earlier, all of these medications have been developed over time to help improve our rejection rates and lower the risk of rejection while also increasing our survival. But it's always a balance, right? So just because we want to give you all these medications to prevent rejection and prevent graft loss, we know that every great medication comes with some side effects. And so we have to balance that very closely to make sure that everyone is tolerating the medications. We also want to prevent certain infections from happening. And then, of course, the risk of malignancy or cancer after transplant is higher. And so we want to balance that. So it's always a balance whenever we talk about immunosuppression medications and the risk of rejection and survival after transplant. So here are a list of some common things that we consider as transplant pharmacists and as transplant centers across the country of maybe what patients will need more immunosuppression or who will need a little bit less. And so not to go into details about all of these different aspects, these are really things that your transplant team will be deciding on when they decide what medications you're going to go home on. But things like younger age, African-American race, and even if you've had a history of organ transplant in the past and then now need a second one, that can increase your risk of rejection. So we may need to give you a little bit more immunosuppression at that time, compared to if you've had maybe a history of infections or other cancers in the past. Maybe you're a little bit on the older side. We may not need to give you as much immunosuppression to give you that same outcome and prevent any side effects from happening. And then lastly, we also take into account what organ transplant you received. And so not every organ is the same in terms of the risk of rejection. So on the left-hand side, you can see things like small bowel and lung transplants. They are much higher risks of rejection, and you need a lot more immunosuppression overall compared to things like your kidney or your liver. You don't need as much. And so all of these things that I've talked about so far will get taken into account to determine what immunosuppressant medications you're going to go home on. All right, so I went through all of organ transplant very quickly, I know that, and the immune system, but I really want to focus on kind of the core aspect of this presentation, which is the common medications that you potentially go home on and what side effects that they potentially can present. So how I broke this up is I will talk about the different classes of medications, and then I listed some common names of these medications that you will probably have recognized or currently be on right now. And so there's a couple different classes of medications that we'll go home on. The first being kind of the most important medication that we have, which is the calcineurin inhibitors, which are things like tacrolimus or cyclosporin. Then we'll talk about the anti-proliferatives or mycophenolate and azathioprine. Then we'll talk about steroids. So these are kind of the three core immunosuppressant medications that every patient is typically sent home on at least right away, depending on the center. And that's something like prednisone. Then we'll talk about the mTOR inhibitors, which are sirolimus and everolimus. And then lastly, the most recent medication that has been brought to the market is the co-stimulation blocker, which is belatacept, which is a very kind of unique medication compared to the rest of them. And I'll explain that as we go. So this is just a full list of the medications, and I'll go through each of them individually. So first, the calcineurin inhibitors. So these are by far the most common post-transplant immunosuppressant that most transplant centers use in the country. Now, when I talk about certain aspects of this, I obviously practice at one center. What we do at University of Maryland may be very different compared to other centers, and that's okay. Not every center has the same protocol. But we all have generally the same aspects that we carry through. What the calcineurin inhibitors showed, and what I kind of pointed out in that graph previously, is that there was increased survival for our patients and decreased rejection overall. So really good trends with these medications to show better outcomes. And now for every different class of medications, I provide a table to hopefully make it simple enough to go through and to understand the different medications. And so you have on the top there tacrolimus and cyclosporin. I listed the common brand names for each of the medications just to make you familiar with the medications that you may go home on. So Prograf is a very common brand name of tacrolimus. And then the newer medications being Astigraf and Envarsus, which are the extended release versions. And then cyclosporin, you have Neoral and Gengraf, which are your common newer medications, and then Sandimmune, which is the older formulation. Overall, all of these medications work to prevent activation of our immune system. So different immune cells don't become activated, so they can't attack that new organ. And that's the base. That's the most important thing that we want to do, is prevent that attacking of our new transplant. So for tacrolimus, the Prograf is twice daily, where the extended release versions, Astigraph and Envarsus, are once daily, and then cyclosporin, they're both twice daily, meaning you would take it once in the morning and once at night. And with the calcineurin inhibitors, there is a certain type of monitoring that needs to happen. So for anyone who's been on these medications in the past, we know that you have to get labs drawn and you have to get a level of this medication taken from your blood to see where you are in terms of preventing rejection. And every person has a specific goal that we're shooting for. And the time frame of when you get those levels monitored is important. So it depends on how you take the medication. So for something like Prograf, for example, you take it once in the morning and once at night. We want to make sure that we get a level right before in the morning. And I have a slide on that next to reiterate that. Important point that I want to point out here is that neither of these medications are interchangeable. So if you're on Prograf, you can't just switch right to Envarsus. There has to be some calculations that go into that. And so your transplant team should be aware of any type of switch that's going on and making sure that it's done appropriately. And you should never cut, crush, or open or manipulate any type of way the different capsules or tablets that we have for any of these medications that I listed here. That would change the way that the medications work and could potentially increase your risk of side effects. So you should always take it as a whole pill or a whole capsule, unless you're told otherwise. So talking about this monitoring and why do I have to get calcineurin inhibitors checked or the level checked, and when do I get this level checked? So the reason that we have to get it checked is to make sure that we have enough of it in our body at one time. We want to make sure that we're able to prevent rejection at a good level. And so levels should be drawn before your morning dose. And so I'm sure for anyone who has been on these medications, you've been told to go get your labs drawn in the morning before you take your dose, whether that be at a LabCorp or a Quest or at your local hospital. Then you can take your medication. And that's so that we get that level right before you take your next dose. And so this is a picture showing first, go get your blood test. Let's say it's 8 o'clock in the morning, and then you get home and you can take those medications around 9 o'clock. Really, the time doesn't necessarily matter. You fit it to your schedule, whatever can work the best. And so that will change depending on what time you take your doses normally and what your normal schedule it is. And there's a reason why we want to make sure that the levels are within our goal. And so this picture on the top there shows different colors, meaning kind of obviously red being, bad, green, good, and yellow, maybe a little bit caution. So we want to have our levels in kind of that sweet spot of the green, and that's to prevent rejection, but also to prevent side effects. And so these levels correlate to kind of too high, too low. We want to make sure we prevent that. And so the pharmacy or your transplant team will always follow up on these levels after you get them drawn to make sure that they're in that green spot, which is the desired level throughout your course of your transplant. But the goal of that level is really dependent on a variety of different things. And so I listed a few here for you. So the time since transplant, so someone who is 1 month post-transplant or 12 months post-transplant may have very different goals of their calcineurin inhibitors because your risk of rejection is a little bit different. The type of transplant, as I already mentioned, and then as I also mentioned, the different centers that you may be transplanted at. So whether you're transplanted at the University of Maryland compared to even something like Johns Hopkins, which is only a few miles down the road, we may have different protocols in terms of what our goals for our calcineurin inhibitors are. So that can vary depending on center. And then depending on any other medical conditions that you may have, we always take that into account to make sure that we don't have any significant side effects to these medications. The most important part is that you will have typically higher concentrations no matter what center you're at during the first year following transplant. And then over time, as your body gets more and more used to this new organ, we can safely lower those goals of your calcineurin inhibitors over time. And this depends on a lot of different things. So it's not standard for everyone, but depending on what side effects you have, if you've had any major infections, or if you've had any episodes of rejection, all of that will get taken into account before we start lowering your immunosuppression over time. And then switching gears to a little bit of the side effects. So it's always important to understand what side effects just to be aware of. These are they do not happen to every single patient, some more than others. It depends on kind of how you're tolerating the medication. So we just want to make sure that you're aware of, things that can happen. So for both medications, both tacrolimus and cyclosporin, all formulations, they can decrease levels of magnesium in your body and increase levels of potassium. So different electrolytes and, different foods can help, mitigate some of those changes. But the bigger thing that I want to highlight is kidney damage. And so I'm sure anyone who has had a kidney transplant in the past and is on these medications is probably sitting there thinking, why am I getting these medications if it's going to hurt my kidney when I just got this nice new kidney that I want to last? And so that's a very good question, and something that, again, it points out to the fact that we need close monitoring of all of your labs. We want to make sure as your transplant team that these medications are in that green zone that I showed prior as much as possible. We really want to prevent them going too high or too low, and that can really help decrease our risk of kidney damage over time. And so that's something that we keep a very close eye on for you, and making sure that that kidney stays healthy for as long as possible. And then for each individual medication, they come with some of their own side effects that we need to just be aware of. So tacrolimus can increase your sugars, can cause some hair loss and potentially some hand tremors, where cyclosporin has some different side effects, such as increasing your cholesterol or blood pressure, maybe some hair growth, and even some swelling in your gums. And so these are important to make sure that we optimize other medications. So if things like your blood sugar are being increased, we want to make sure that your insulin or any other type of diabetic medications are under control. Or if you're not on any of those medications, that we make sure that we decrease it as much as possible. Or if they're really bad and the side effects are intolerable to the point where you can't even live a normal day, let's say you're having really bad tremors on tacrolimus, and you can't even drink a glass of water without spilling it, that's not going to be healthy. We don't want you to have to go through that. So we may need to switch to another agent to help change some of those side effects. And so this always, I want to highlight here, and I'll talk about this a few times. These are always discussions that you want to have with your transplant team. None of these decisions should be made on your own. You should always make sure that you're discussing any of these side effects that you're having to your transplant team, so we can make sure we handle that appropriately. And then drug interactions. So there are a lot of drugs that we need to worry about with calcineurin inhibitors. All right, drug interactions are common in this specific type of class of medications. And now that's not to say that you need to be worried about taking other medications. The thing I want to highlight is that you want to make sure that you contact your transplant team, your coordinator, or your local pharmacist, at a CVS or Walgreens, before starting any new medication. The reason for that is you're on a lot of medications at the time of transplant, and we know as your team that they are safe together, and we are monitoring that appropriately. But in a year, 2 years, as you see us less often, and you may be seeing your primary care physician, or you may see other doctors, they may prescribe medications and not realize the interactions that it has with your immunosuppressant medications. So you should just always contact someone before starting any new medication to make sure that it is safe. But what I did want to highlight are a few just to be aware of, especially for certain times right now with COVID. The first one on this list, which is called Paxlovid, which some of you may have heard of. This is a medication that is used to treat certain virus, and most recently has been shown to help decrease the symptoms of COVID. This medication can cause a very significant increase in your tacrolimus or cyclosporin levels. Your transplant team should 100% be aware that you are being started on this medication. Okay, so as a transplant team, we've had some experience with this medication. We know that the levels go very high, and we need to make sure that we're monitoring very closely, at least have a plan for the patient. And we want to make sure that we're aware of it. And sometimes if a patient doesn't tell us, then we don't know. So if you're seeing an urgent care doctor, or let's say you're seeing your primary care doctor and they say that they want to start you on Paxlovid, you should make sure that you're contacting your transplant team right away. The other medications I have, some medications, some common juices that we may have obviously enjoyed at one point. So St. John's wort is an herbal supplement that can help with depression, grapefruit juice, which is obviously a common juice that people may enjoy, and then non-steroidal anti-inflammatory drugs. So all of these medications can interact with your tacrolimus or cyclosporin levels. And the NSAIDs can just increase our risk of kidney damage when taken with the calcineurin inhibitors, as I mentioned that they already have the risk of kidney damage. So what I want to point out with all three of these, St. John's wort, grapefruit juice, and any NSAID, so things like ibuprofen, naproxen, any type of brand name medication that has the non-steroidal component to it, is to avoid these medications. These can lead to unsafe levels of your medication and can also cause harm. So we ask that all patients typically avoid these. The one caveat is that a lot of patients typically are on a baby aspirin, so 81 milligrams of aspirin. That is 100% okay. You do not have to worry about that as an interaction. So continue to take that. And if you have concerns, just make sure you talk to your team about that. All right, so that's all for the calcineurin inhibitors. That is the most difficult of the medications that we'll talk about today because of some of those monitoring parameters and also just some of the side effects, but it is the most important medication as well. So that's why I spend the most time on that one. So antiproliferatives are the second most common immunosuppressant used after transplant. And again, I have the same table listed here for you with the different brands of the medication, how it works, and so on. So you'll commonly hear mycophenolate as Cellcept or Myfortic, and then azathioprine as Imuran. This helps with preventing the replication of some of our immune system, and the dosing is listed there for you. And so Myfortic and Cellcept are both taken twice a day, and azathioprine is taken once a day. We don't need to monitor anything for these medications, meaning you don't need to get any levels taken in your blood. That is just for the calcineurin inhibitors. And then the special considerations I also want to point out. So for both mycophenolate and azathioprine, they are not interchangeable, so you can't just switch from one to the other. There has to be a dosing change to those. Mycophenolate is contraindicated in pregnant women and in patients who are around pregnant women. So I will talk about that in a slide next. And then the mycophenolate product should also not be cut or crushed or manipulated in any way. Whereas the azathioprine, if you really need to, or if you're having trouble swallowing the pill, you can crush the pill. So I mentioned pregnancy. And so mycophenolate has been shown to increase the risk of birth defects and pregnancy loss, especially in the first trimester. So really what I want to highlight here is that prevention and planning are key. So we ask that all females that are in childbearing potential age, that they use 2 forms of contraception at the time of transplant, and for at least 1 year typically is for what most centers recommend, to make sure that we are having adequate protection. If for whatever reason you do become pregnant, which does happen, or at least if you're thinking of becoming pregnant and want to have that discussion, you should always talk to your transplant team immediately, especially if you do become pregnant at the time and realize that you're pregnant while you're on mycophenolate due to the risk of these side effects. And then there is a reporting system that's available if you were to become pregnant. If anyone has any questions about that, I can definitely speak to that a little bit more at the end. But the biggest thing is that prevention and planning are key. And if you are around someone who also is pregnant, they should not be handling the pills or really kind of, being around much of them if possible, just because of the hazardous aspect of them. So side effects. So again, both of these medications, they can cause low white blood cells and low platelets. So these are different cells in your body that can be affected by these medications, and something that the transplant team will always monitor for. And if they do happen, we can sometimes decrease the dose. And so that can help, change some of these side effects that you may be experiencing. This is, again, something that you want to make sure you're talking with the transplant team before changing any of your doses. And then for each individual medication, mycophenolate, a lot of GI upset, so diarrhea, nausea, vomiting, are all fairly common side effects to this medication that some of you may have experienced or may experience. And then azathioprine can cause hair loss and potentially some upset stomach, but not as much. So for the mycophenolate, there's a few things that can help. decrease some of these side effects. So we can change from Cellcept, if you're on Cellcept, to Myfortic, which is the slow release tab. And I have a little picture there on the right that shows kind of why that helps. So you can see the blue line, which is the conventional one, which is Cellcept. You have that kind of high peak, and then it slowly starts to come down over time. Whereas the sustained release, you have less of that peak, and it's a slower decrease over time. And that helps some of these GI effects that have been associated with these medications. And so if that is something that you're experiencing on Cellcept, you can talk to your team. Maybe they can switch you over to Myfortic. Or if you're already on Myfortic, there's things that we can do to potentially help as well, which is take smaller doses more frequently. And I have an example there. So if, let's say, you're taking 360 milligrams twice a day, we could potentially change you to 180 milligrams 4 times a day. So you're still getting the same amount of medication throughout the day, but less of the peak that is associated with some of these side effects. So talk to your team if that's something that you're experiencing. We can also decrease the dose or change to another medication if that is also something that is happening. And then for azathioprine, what has been shown to help is to take it with food or potentially decrease the dose if your transplant team thinks that that is safe. So again, talking to them and making a plan and making them aware of the side effects that you're experiencing.
Are they good?
All right, so the third class of medications, steroids. These, again, were the first used immunosuppressant in organ transplant and is really a part of most regimens across the country and in different ways and different doses, which we'll get into, but really kind of one of the standard medications that are used. I listed a couple of the common medications that you'll hear of. So prednisone, prednisolone, or methylprednisolone, all of these are common steroids that are used after transplant, and they affect a lot of different parts of our immune system. And there's multiple ways in which they help prevent rejection. They typically are taken once daily with high doses given kind of right at the time of your operation and then decreased over time. And then again, depending on what center you're at, they may be decreased more quickly or a little bit slower. It really just depends on where you were transplanted. Again, monitoring is not needed for any of these medications either. You can crush most of these tablets or cut them if you need to, which makes them a little bit easier to take. And if you need to take them with food, that can help prevent some of the stomach upset. I know that not many people enjoy taking steroids, a lot of side effects associated with which we'll talk about, but these are very important medications as well. So side effects. We'll break the side effects down into short and long-term side effects. And so there's differences in kind of how long you're taking them and what they can actually cause. So the short-term side effects are listed here. So things like increasing in your blood pressure, maybe increasing in your sugars. You may have trouble sleeping, maybe feeling like a little confused or just like not like yourself. They may cause you to have some swelling in your face or maybe even cause issues with your stomach. So obviously none of these are great side effects. We try to eliminate a lot of these if we can. But if we really need the patient to be on the steroid, there are things that we can do to help some of those side effects. So we may need to help kind of remove some of that fluid that you have that's sitting around in your face with other medications that help kind of get you to get some of that excess fluid off. We may need to give you some insulin temporarily to get your sugars under control. We may need to optimize some other medications, so things like your blood pressure medications. If we can, we'll reduce the dose or potentially even stop altogether. And then for stomach issues, we can give you some things like acid reducers to help prevent any ulcers from forming. Now, those are the short-term effects. Now, if you're on steroids for a long time, there's some other side effects that also can occur. And this is really why most centers try to take you off steroids as quick as possible, but also at least try to minimize the dose as much as we can. So it can cause increase in your cholesterol, can change your growth suppression, the ability for your bones and your body to grow, and then also can affect your bones over time. And so this is where you may need some cholesterol lowering medications, so things like your statins. We will give you some vitamin D and calcium to promote some bone growth, and then also reduce or stop if we can. So these are ways that we manage some of these side effects if the steroid is, necessary to continue for your transplant. Switching to the mTOR inhibitors. So these next few classes of medications are a little bit less commonly used, not to say that you won't be on them, and not to say that they're not effective, because they both are very effective in preventing rejection. But there's just some caveats to kind of why we use them and which patients we actually use them for. So these are primarily used to decrease those kidney effects that we see from the calcineurin inhibitors like tacrolimus and cyclosporin. So they do not have those same effects. The common medications are sirolimus or Rapamune, and then everolimus and Zortress. So those are the brand names. Again, they help with the prevention of your immune cells from replicating. Sirolimus is taken once a day, where everolimus is taken twice a day. And again, the monitoring is very similar to the calcineurin inhibitors. So if you're on sirolimus, you'll need troughs or levels at 24 hours, and everolimus, you'll need a level at 12 hours. So very similar process, which I'll talk about in a slide. Again, I have that you should not cut, crush, or chew any of these medications, but these medications have also shown to reduce the risk of certain cancers. And so this is another area where we see these medications used often. The monitoring is very similar to what we talked about with calcineurin inhibitors. So there's that green zone that we want to keep you in as much as possible, which is our goal level. And we want to prevent it from going too high or too low. The same factors are really dependent on what will have your goal at after transplant. So how far out from transplant you are, what type of transplant you received, where your transplant center is and what their protocols are. If you're on other immunosuppressant medications like the calcineurin inhibitors or the antiproliferatives, will balance all of these medications out. And then again, other medical conditions. So all of the same factors that I talked about for the calcineurin inhibitors. And again, the drug interactions are also the same. So this is the same slide that I showed earlier. There are a lot of drug interactions with these medications as well. They are metabolized the same way as our tacrolimus and cyclosporin are. And so there's other interactions that can occur. So things like Paxlovid, grapefruit juice, all of those still apply, and we should avoid those medications if possible. If you're prescribed Paxlovid and you're on sirolimus or everolimus, you should make sure you contact your transplant team right away. And then some side effects for the mTOR inhibitors. And this is really what has limited the use of these medications really widely across the United States, is that there are a little bit more side effects that we do worry about. And so the big ones that I want to point out are the impaired wound healing. So if you've had any major surgery, or if you're planning for any major surgery that's outside of what your transplant team is aware of, you should make sure that your team knows that you're about to have surgery, because we may need to switch you off of these medications. If you're experiencing any bad mouth sores or acne, that can also happen. You should let us know. And then there's other things, again, swelling, increasing cholesterol can affect some of our white blood cells and platelets. So, we have to monitor these very closely as well, similar to all of our other medications, to make sure that they continue to be safe and effective for you. And again, all of those same things still apply. So we may need some other cholesterol lowering medications. We may need to decrease the dose, or kind of the goal, that green zone that we're shooting for in terms of what your levels are. We may need to limit the use in certain patients. So again, depending on what types of other medical conditions that you have, we may need to not use these or switch them off if necessary. And then lastly, the last class of medication that I'll talk about is the newest medication, which is the co-stimulation blocker. And I won't necessarily get into what that means, but it's a kind of a unique mechanism of how it works. And this has also been shown to decrease the kidney effects that we had with our calcineurin inhibitors, which are the tacrolimus and cyclosporin. So the difference about this medication is that this is an IV medication. So you would get this either at an infusion center or potentially even at home if we set up in a home infusion. And it works a little bit differently compared to something like our tacrolimus and cyclosporin. And you'll see that not only is it given as an infusion, but it's usually only given once a month after you get through the initial kind of loading dose, we'll say. So you'll get it a little bit more frequently up front. And then it'll typically be only every month. We don't need to monitor for this medication, and it's generally very well tolerated. So you may be thinking like, this sounds pretty nice. I only have to take it once a month. It's an IV. I don't have to take something every single day. It's very well tolerated. There's not a lot of side effects. Why not everyone get a co-stimulation blocker or belatacept? The risk is that there are certain risks of increased cancers, of certain types of cancers. It may help improve adherence because you don't have to take a medication by mouth every single day. But it has been shown that it's not as effective as our calcineurin inhibitors, and some of our other medications have been shown to decrease the risk of rejection. So it is a great medication. There are a lot of people that may be on this medication. We, as a transplant center at the University of Maryland, do use this medication fairly often, but there's a very specific patient population that we use it for. And so it's not for everyone. And so it sounds great, but some of those other medications I already talked about are kind of the core medications we use for a reason. So just to kind of highlight the final reminders about immunosuppression. I know I talked a lot about all the different information, and that's why I'm happy that this is recorded and you can refer back to this anytime you need, is that immunosuppressant medications, they have increased the life of organs and patients, which is a tremendous thing and very exciting for our field. You should always talk with your transplant team or a pharmacist if you're experiencing any side effects, so we can make sure that we manage those appropriately. And lastly, and most importantly, never stop taking your medications on your own. Even if you're having, very bad side effects or things that you think are, not able to tolerate, you want to make sure you talk to your transplant team right away, and we can help you through those side effects and try to come up with a plan together. We don't want you to ever stop taking these medications on your own, as that can lead to a lot of complications for your transplant. All right, so we talked about all the medications and the side effects. We're going to switch gears in terms of how to prevent infections after transplant. And so the reason why infection prevention is even more important after transplant is that now we have a weakened immune system. So because we're giving you all of these immunosuppressant medications to prevent your body from rejecting your organ, your body doesn't have that same ability to mount an immune response to other things like infections. So after transplant, you may be a little bit more likely to get infections. It may be a little bit harder to know that you have an infection because your body's immune system doesn't mount that same response. So you may have less signs and symptoms. So for example, you may not have as high of a fever anymore after transplant. And so we have to be extra cautious. And it may just take you a little bit longer to heal and recover overall. And so we have to balance kind of that risk of rejection and the risk of infection. And after transplant, we'll give you certain medications, anti-infective medications, to prevent the infections when they're at the highest risk. And there's 3 different classes of infections that we'll talk about. So bacteria infections, viral infections or viruses, and then fungal infections. So the first one is bacteria infections or bacteria prevention. The most common medication we use for this, and now depending again on the center that you use or that you have your transplant at, is Bactrim. This prevents a certain type of pneumonia or urinary tract infections. The duration of how long you'll be on this medication really depends on kind of what organ you received and where you got transplanted. And there's some side effects listed there for you, but I won't go into those in detail. And I also listed some alternatives that we may use in case Bactrim you're not maybe able to tolerate it. Maybe you have an allergy to Bactrim. So things like Dapsone, Atovacone, or even an inhaled medication may be used to prevent bacterial infections after transplant. For viral protection or prevention, the most common medication we use is valganciclovir or Valsite. And this is to prevent a certain type of virus called cytomegalovirus or CMV. Again, the duration of how long you'll be on this will depend on what your risk for CMV is, which I won't get into for today, and the type of organ that you received. And again, I listed side effects and alternatives to potentially that you may have been on or may be on in the future. And then fungal prevention. Now, there's quite a few common medications that are used, and this really depends on what type of organ and transplant center you're at. So things like nystatin, fluconazole, voriconazole, all different medications that all prevent different fungal infections with different side effects and nuances about them. I really didn't get into the details of these because it really depends on what type of organ you received and where you got your transplant. So I didn't want to spend too much time on these, but you will be on certain medications after transplant to prevent a fungal infection. All right, so we talked about preventing infection. Now I want to spend some time before I open up the floor for questions on how we can develop strategies to take all these medications. So I just talked a lot about all of the importance of these medications. I talked about, how they work, how they prevent rejection and increase your chances of survival over time. But unfortunately, unless we take these medications, they're not going to help us. And so I really wanted to highlight as a pharmacist, ways that we can help that happen as much as possible. And I know it's not easy. There's a lot of medications that we send you home on and a lot to remember, but there are tools out there to help you with this. So the first example I have is a medication folder. Now, this is a folder that we provide at the University of Maryland, so it may be different every center, but this is how it's shown. And this can really keep us on track in terms of what medications we're on, what the dose is, how many times a day we're taking it, and when we should actually be taking it. And this can help keep you organized to make sure that we're taking those medications on time. There are things that you can set up on your phone with your pharmacy. So this is an example of your refill is ready at the Rite Aid. You can, ready to come fill it and come pick it up. So it's encouraged to set up these automatic replies to make sure that you know when your medications are ready. Setting alarms, as tedious as this may sound, setting an alarm on our phone, multiple times per day, but it can really help keep us accountable to make sure that we don't forget. It is very difficult to remember something when you're busy and when you're out of the house, but setting these alarms can really help allow us to not forget. Setting up automatic refill reminders with your pharmacy. So a lot of pharmacies offer this, where every month when the time is ready to refill the medication, they will automatically do so. So I encourage you to ask all of your local pharmacies if that's something that they can do. And then there's also, now with all these smartphones and all the different technology we have, different apps on your phone that can help you kind of set alarms, manage your medications, and keep everything in track. And then there's pill boxes. So again, this is an example of a pill box that we give at Maryland. There are many different types of pill boxes that are offered. As long as you have one, there's ones that have just the week, there's months, there's kind of all kinds of different setups. But we definitely encourage using a pill box, setting a time every week to fill your pill box to make it easier for you to take your medications throughout the day and throughout the week. There's also pharmacies that offer pre-packed pill boxes as well. So I encourage you to ask your local pharmacy if this is something that they offer. Now, depending on how far out from transplant you are, this may be easier to do when if you're a little bit further out from transplant and your medications aren't changing very often, you can have this set up for you. And this comes in a nice packed pill. You just kind of pop that slot out when it's time to take those medications, and you don't have to worry about filling it. And then lastly, there's these newer pill boxes that are available that combine multiple different aspects of what I talked about, where it'll set alarms and it'll kind of alert you when it's time to fill those or to take those medications, which I think is really unique, kind of combines multiple aspects into one. So all different types of tools, not everything is for every person, but, definitely a lot of different things available to take your medications. But I think the most important thing that we encourage is to really take an active role in your transplant and in your medication. So we really encourage you to know as much about your medications as possible. I understand that, all the names can get confusing. The doses change fairly often, what they're used for, what side effects it's a lot of information. But the more you know about your medications, the better off that it will be. And then there's a lot of questions that you can ask yourself about your medications, which I'm going to go through one at a time here. So do I take my medication with or without food? This is a very common question that comes up to us as pharmacists. Some people enjoy kind of getting up maybe in the morning, eating a little bit first before they take all of their medications. And so other people don't. But food and drinks can sometimes change how much is absorbed in our body. So it can lower the amount or kind of delay the time that it takes for our medications to be absorbed into our body. And some food or juices can actually change, how fast it is broken down in your body. So there are effects that we do need to be aware of. But I think the biggest point that I'll highlight here is that you should always just check with your local pharmacist what medications can or cannot be taken with food. And usually you'll see a sticker that I have down on the bottom there on your pill bottle. And you should always be consistent. So for your transplant medication specifically, it's okay if you take your food or take your medications after eating in the morning or at night. The biggest thing is you just want to be consistent, because we can adjust how much you need to take depending on how much food or drink you're taking. If the medication can't be taken with food, there's some parameters there that I listed as well. But really the biggest thing is to check with the pharmacist and be consistent. What happens if I forget a dose? So I know I just talked about a lot of different ways to make sure we don't miss doses, but I also understand as a human that it is going to happen. You're going to be out one day, you're going to maybe fall asleep a little earlier than you planned. It happens. It's okay. We just want to make sure that it doesn't happen all the time. But there are kind of some rules that you can follow in terms of when and if you should take the dose when you realize you missed it. So the general rule is, as long as it's within a few hours of that missed dose, you should take that missed dose. Now, I broke it down into kind of how often you take your medication, and I can try to provide some examples. So for that second bullet point, if the medication is taken once a day, so that means you take it every 24 hours, and let's say you take it at 8 a.m. every morning. If you remember, as long as it's within half of the time that your full interval, so meaning if you take it 24 hours every day, if you remember within 12 hours, which is half of that 24-hour time frame, it's typically safe to take that medication. Anything after that, you should just wait until your next dose. Now, if you take it twice a day, that means you take it every 12 hours. If you remember within 6 hours, which is half of that interval, then you should take that dose as well. And then again, if you take it 3 times a day, you just continue to divide that time frame in half. The most important part is that you just don't want to ever double up. You don't want to have to cause more. It can cause more side effects and more harm if you try to take both of the doses at the same time. And so that's really where we try to advocate for not missing as many doses as possible, so you don't run into those situations where you feel like you have to double up, but trying to following those other rules that I mentioned earlier. What happens if I run out of my medications? So this is obviously not something that we want to happen. If you run out of your medications, that can quickly increase your risk of rejection. So you really should try to stay as on top of it as possible. And that's where those automatic refills can be advantageous to you, and really kind of keeping on track with your pharmacy to make sure that everything's getting filled on time. Our typical rule of thumb is that when you have 1 week left of your medication in your pill bottle or in your pill box, you should call your pharmacy to see if they can refill it. Whether that's going to get delivered to you, you have to go pick it up, making sure you have plenty of time to get that medication. If for whatever reason you do run out of your medication completely, you should contact your pharmacy and your transplant team right away so that they can help try to get you medications as quickly as possible. What if I can't afford my medication? I understand that a lot of these medications are very costly, depending on what type of insurance plan you have. These things can quickly add up, but there is ways that we can help. So talk to your pharmacy, talk to social work when you're in the hospital, or talk to your team to get you in contact with them. There are a lot of different assistance programs that are out there for these transplant medications. Some of them offer copay cards to help with the copays that you may have. There's different grants available to help pay certain patients for medications. And then ask about generics. There may be some generics available, especially as we've gotten further along from their development, that may be available and may be a little bit cheaper. And then we may be able to change you to an alternative medication that's a little bit cheaper. So talking with us if you're having issues with your payments ahead of time and before it kind of gets to the point where you need to stop it altogether. And then are other medications safe with my transplant medication? So again, I've talked about this and probably sound like a broken record at this point, but always contact your team to see if it's safe. Again, your local pharmacist, your transplant pharmacist can help answer those questions. And make sure that everyone knows that you have a history of transplant. You know, your primary care doctor, depending on how close you are with them, depending on how new they are, they may not know that you have a transplant. Making them aware of that is very important to know what medications may be safe. And then if you're having, you know, other symptoms, like let's say you have a cold and you're taking, you know, over-the-counter medications, you should contact your team if things don't change within about 48 hours is the general rule. And then, of course, all of your other medications after transplant are still important. So I know I focused more on the immunosuppressant medications, but you may be on other medications for pain or for blood pressure or for diabetes. Those are all still very important medications. You never want to stop taking them. We know that most of them are safe with your transplant medications and for the new transplanted organs. But if you're ever again, you know, if you have questions about starting or stopping, just contact your transplant team to make sure that they are safe. So to wrap all of this up, I know I've been talking for a while. I might have went a little bit over, but I'm happy to stay and answer any questions. A successful transplant is really dependent on you. You know, as much involvement as you get with your medications and the more knowledge you have on them, the better off you will do. Immunosuppressant medications have drastically increased the life of our organ transplants and our patients, and which kind of explains why, because they're so important. Always talk with your transplant doctor or your local pharmacist about side effects that you may be having. Know your medications and always ask questions. There are no silly questions. Please ask anyone that you have at your disposal to make sure that your questions are being answered. And then always take your medications as prescribed to protect your new organ and to protect your body as much as possible. And I am happy to stay and answer any questions. I'm going to stop sharing my screen. Actually, I can see the chat, so I might be able to do both. Seems like there's a lot of questions here.
Ian, I tell you, you were really worth the wait. So this was great. Thank you. Can you take your sharing down and then you can see a lot of faces maybe? There you go. Super.
Yeah,
Thank
yep.
you.
There we go. So I see a lot of questions. I'm going to try to start from the top. All right. So I see, will we receive certificates for attendance? I will defer that question to Michelle and Marty.
No, I had answered it in the chat, but no,
Perfect.
you will not. Thank
Okay.
you.
So Lisha Taylor said that I was her transplant pharmacist in March of 2022. I actually do remember the name. So I don't know if I see your face, but welcome. I'm happy that you joined, and I'm glad that I was a great pharmacist and helpful back in the day. So that's great to hear. 10 years into a heart transplant, which includes prednisone, Myfortic, and Prograf. All of a sudden, my white blood cell count is recording as extremely low after tests. Know why?
Ian,
you know,
Ian,
Sure.
Ian, okay. I think I can answer that because of your presentation.
Okay, well, great.
I've been on Myfortic since 2013. In 2021, I got an infection and almost lost my heart. But they applied me full of steroids. I went now back onto Valtrex. And it also caused me to go into diabetes now, insulin dependent. The transplant team, by the way, I'm University of Maryland. Transplant team took me off of Myfortic. So I've been off of it for 2 weeks because of the low blood cell count. And I'm also realizing from your presentation that the Valtrex, the infection medication, can also lower my white blood cell count. So that's why they took me off the Myfortic.
Yeah,
and monitoring me now for that.
Yep, absolutely. I think that definitely explains it. You know, the addition of that other medication can sometimes, you know, tip you over the edge a little bit where your body can't, you know, help as much. And if you're dealing with an infection at the same time, that can definitely happen. So it's that balance that we talked about. You know, your team will you know, change things, lower certain medications, increase other ones to make sure that everything works out well. And I probably know the team that you're working with over at Maryland if you're still being followed at Maryland. So that's great.
Thank you. Thank you.
Yeah.
Good job.
Thank you. All right, I'm gonna try. On the slide with the graph of survival rate and rejections, there was a major step function in 1995. What happened? Let me just go back to the presentation to look exactly at what time you're seeing. So around 1995, there was probably the more widespread use of a lot of those medications that came out in the 1990s. So tacrolimus, mycophenolate, sirolimus all started to being used. And then, we really saw kind of a drastic change. So probably just more widespread use of those medications as the time has gone on, probably helped with those kind of drastic changes in rejection rates overall would be my guess. All right, question, if the med is described 2 times a day like Prograf, how critical is it to take the 2 dosages exactly 12 hours apart consistently? Couldn't lab results be skewed if the blood draw happens plus or minus a few hours based on the usual schedule? So that's a very good question. Now, in an ideal world, if I were as the pharmacist that I am, yes, the 12 hours apart and the consistency is key. But as a human who has to, has a life and has to, do other things outside of just sit and take medications all day, it is understandable if there's fluctuation in that. So what I always usually tell my patients when I'm talking about that 12 hours is there's usually like a window of like 1 or 2 hours on either side. So if let's say you take your medications at 8 a.m. and 8 p.m., if you wind up taking them at 7 or 9 a.m. and then again, 7, 9 p.m. at night, that is completely fine. Really, as long as you're taking them, that's more important than that 12 hours exactly. The 12 hours really gets into the fact that we want to try to check a level exactly at that 12-hour mark, which we again realize that that's not ideal in everyone's situation. When you're right after a transplant and you're in the hospital, we can do that. You're, kind of stuck in a bed and you don't really have anywhere to go. But when you're home, you may have to go to work in the morning. You may have other things you have to take care of. So getting that level as close to the 12-hour time is as important as possible, but we can monitor it depending on what the actual time is. So kidney transplant here, 3 years, still on prednisone, which concerns some of my other doctors. Can I expect to come off the prednisone ever? That's a very good question. Unfortunately, depending on where you were transplanted and other risk factors that you may have, I can't answer that question, as a global yes or no. I would say my advice would be to talk to your transplant team and see what options they may have. Again, every transplant center has different protocols. They may keep you on steroids a little bit longer, depending on your history of rejection or other types of infections, things like that. So communicate with your transplant team, let them know the concerns that you and your other providers and doctors have, and see what kind of options they have for you and what they may suggest. And then I see a comment actually to the previous question that I answered about that 1 hour window to get labs drawn, which is perfectly fine for that window. Are sinus meds okay? That's a good question. So a lot of over-the-counter sinus medications are okay. There's usually a list that the transplant team will provide you, depending on other medical conditions that you have. Decongestants you do have to be careful of if you have high blood pressure, things like that. But if you need to take something for allergies or anything like that, nasal sprays, those are typically okay. But again, this is where that rule of thumb of, if you're having symptoms for more than about 48 hours, you should contact your transplant team. They may want to get you seen to make sure that there's no major infection going on that they want to be aware of. So there's a comment here or a question here about commenting on the side effects of statins, like atorvastatin. If lipid profile numbers are good, rather not take it if there are bad side effects. So there are some side effects with statins that you do need to be aware of. I think the biggest one that most people hear about is kind of like muscle aches and pains that can somewhat be significant down the road if it's really bad. Typically, though, otherwise, statins are relatively safe. They've shown a lot of different benefits. So if your lipid profile numbers are good, it may be because of the statin that's actually working. Again, I kind of, other than the side effects and the safety with your immunosuppressants, I would talk to the doctor that prescribed them and see if if they can work a plan to see if you can get your cholesterol lowered on your own with maybe even like diet controlled, But, depending on what other conditions you may have, sometimes statins are preferred and do have a lot of different benefits. So talk to your team, voice that. That's more than okay. How common are gut issues if on CellCept? The GI issues, the gut issues are fairly common with the CellCept products. Some people just don't really tolerate them very well. As I mentioned, there's some things that we can do with your transplant team, maybe spacing the doses a little bit, maybe lowering the dose if we're able to, depending on when your transplant was. But unfortunately, that is one of the more common side effects of CellCept specifically. But maybe talk to your team and see what other options you may have to help eliminate some of that. And then you can also try taking it with food, see if that helps a little bit. Again, I said you should be consistent with that food intake if you're taking it with your medications, but you can try that and see if that helps a little bit as well. BKV, I see on there, please explain. I think unfortunately that's probably a topic for another day. BK virus is a pretty lengthy topic on its own. It's a certain virus that can happen in specifically kidney transplants that can affect kind of your kidney itself. And that's why, we want to minimize immunosuppression as much as possible when we can. But if you have other further questions, I would probably talk to your team, or if you have BK virus, I would probably talk to your team to make sure that it's, they're following up on it. Can myfortic cause hyperglycemias? Not typically. It's not something that we would usually worry about with myfortic specifically. That's typically more your calcineurin inhibitors and your steroids. So if you are having hyperglycemia and you're only on a myfortic product, not something that I would typically worry about. How high a dose of steroids are you given at surgery? So this depends on, again, what type of transplant you're receiving and what type of transplant center. So for example, let's say it's a kidney at University of Maryland. We typically give 500 milligrams of an IV medication in the OR, and then that's slowly lowered over the course of 3-4 weeks, depending on your risk overall. That may change depending on, again, what type of transplant you have, though. It sometimes is a little bit higher, sometimes a little bit less. Are there some centers where they have a no prednisone protocol? What would they use instead? Typically, from what I understand, most centers will use some steroids. The difference is that some centers will do a steroid taper over about a month. Some centers will do a taper over about 3 to 6 months. It really just depends on kind of where the surgeons and the team are from to develop those protocols and kind of their stand on kind of the literature that's out there to support them. There's a lot of different, opinions that are out there. For example, like our center, though, we would be considered more of the short taper where we'd get patients off over the first month, but it really just depends. Does the body ever recognize that the transplanted organ is no longer foreign? And are you able to get off immunosuppressants after years of taking meds? That is a very great question. In my experience so far, I've been practicing for about 5 years or so total now. I have seen one kidney transplant patient completely off of immunosuppressants and still doing very well. But I will say that is very rare. Typically, you can lower the amount you need over time, and we can get you to a fairly low dose, but you typically will need something. And then, your center will drive kind of what that something is. But it has happened, and it's very unique when it does. mTOR inhibitor to decrease vasculopathy. Absolutely. That's one of the main reasons we use that in heart transplant. Someone knows their immunosuppressants very well. That's great. Does the immune system gradually become more efficient? We talked about that a little bit. Will these slides be made available to us? I believe that the recording will all be made available. There's a question in here about their child is going to be getting a kidney transplant and has never been able to take pills. That is definitely a great question. I know at our center, for anyone in the pediatric world, a lot of these medications come as suspensions or solutions that can be taken as well. So you'll talk to your transplant team, and if that is going to be an issue, they can work with you to make sure that they get those medications approved, first of all, and then also they'll work with you to teach you how to draw them up correctly, how to give them properly. But there's a lot of different teaching that can go into that, depending on where your daughter is listed for transplant. But we definitely have options for that to make sure that they can get the medications. But that is a very good question. Strategies to prevent mouth sores with sirolimus. That's a very good question as well. Talk to your transplant team. There are some products that you can use that contain kind of like a lidocaine solution that you can swish around in your mouth that sometimes helps with the pain associated with some of those mouth sores. Depending on, again, a lot of the other factors we talked about, you may need to slowly lower some of those doses. And unfortunately, if they don't get better, sometimes we have to take you off of the medication completely. But talk to your team if that's something that's continuing to bother you. If it's getting worse, that's definitely something that we can work through. There are some products to help with that, though. What are the cancers? Which types of cancers? I'm trying to time the 1141. I was probably talking about the belatacept product. There's a certain type of cancer called PTLD, which is post-transplant lymphoproliferative disorder that has been associated with belatacept. Again, it's fairly rare overall, but just something that they did see when they were developing the drug. So something to just your team will be monitoring and making sure that there's no increased risk overall. What advancements have there been to improve immunosuppressant drugs in terms of impacting kidneys after transplant? Are there new drugs in the pipeline? So I think one of the biggest changes was that belatacept. That's one of the fairly new medications and very different mechanism, as I talked about, and kind of unique properties and how it's given. That was a big breakthrough for us to have that availability. And there are definitely a lot of other drugs in the pipeline, other medications similar to the belatacept. Other formulations of even tacrolimus. So definitely a new area of research. Hopefully, that continues to progress and we have more options to, continue to move the needle in the right direction where we can keep these organs even longer and keep our patients, safe with less side effects as long as possible. But definitely things in the works. What about certain foods with decreased absorption of our meds? It really just depends on the medication. Some medications are affected by like high fatty meals. Some are affected by any types of food. Really, the concept I was trying to point out is that for your immunosuppressant medication, specifically, if you eat kind of like a big bulky breakfast in the morning and then take all your medications, the drug just has more to work through to get absorbed into your blood, which is where it really is going to work. So we really just try to say that, if you do need to eat something, probably a little bit lighter of a meal would be helpful. And then just trying to be a little bit more consistent with that to make sure that, you get as much of the drug in your system as much as we can. Should transplant recipients wear a medical ID? That's a very good question. I don't know the answer if that's available. I know they make certain types of IDs for patients that are on like warfarin or any types of anticoagulation. But that's a very good question. I don't think it would hurt if that's something that you're interested in. I'm sure that there's somewhere out there that you can get that made. Etsy, all these shops that come up that you can buy kind of all different things. But your transplant team may also have some resources to get something like that too.
Start a new chat. Can you start a new chat?
And it looks like somebody else answered yes as well.
Yeah, we're gonna try and wrap this up for everyone. I don't know if you have a couple more here, Ian.
Looks like there's probably some other ones going down, but I'm happy to stop there. If anyone has questions, they can reach out to you and Marty, and if you want to pass them along my way, that's fine. If I didn't get to them, I understand it's already 12:15. So
That's great. We really appreciate the extra time. Like I said, our group always does have a lot of questions. And if you do send me a question, I will forward it on to Ian. So no worries there, okay?
awesome.
Thank you again, Ian. It was awesome, as everyone has commented here in the chat feature.
Yeah,
And
thank you for having me.
It was great, Ian. Thank you very much. I'd like to thank everybody else for attending today. It was great seeing everyone's face and hearing your voices on the chat. We want you to check out our website on the events page for upcoming future meetings. We have quite a few on there all the way up till July this year. Check out our website, www.triomaryland.org. All our past meetings are posted to our YouTube channels. And Ian's notes will be in the speaker notes on our webpage. We also would like to wish everyone a happy Valentine's Day. We won't see you before that day, and we just wanted to say happy Valentine's Day. Don't forget to like us on Facebook and Twitter, and we'll see you guys on March 11th. Thanks
Bye,
for attending.
everybody. Have a great weekend.
Thanks,
Thank you,
everybody.
Ian.